It's my pleasure to introduce our speaker for today, who's a distinguished consultant at KSU-MC and my senior colleague and mentor, Dr. Ismail AlGhamdi. Dr. Ismail earned his MBBS from King Khalid University and then completed the Saudi board in 2007. He then completed 2 fellowships at King Khalid Eye Specialist Hospital, first in cornea, cataract, and refractive surgery in 2008, followed by Pediatric Ophthalmology and Strabismus in 2010. He has been a board-certified consultant since 2010 with more than 20 years of academic, clinical, and surgical experience. His experience as a consultant includes serving at King Faisal Specialist Hospital and Research Center, Prince Sultan Military Medical City, and King Saud University Medical City, where he also served as the head of the eye unit at King Khalid University Hospital. Dr. Ghamdi, and I attest to this personally, is widely recognized for his exceptional teaching and mentorship of residents and fellows. He has received multiple letters of appreciation and Best Teacher Awards and from national and regional ophthalmology programs. His scholarly contributions include over 10 peer-reviewed publications, book chapters, and presentations at international conferences such as the World Ophthalmology Congress. Today we're lucky to learn from his vast experience and from some of the challenging cases that he encountered during his career in his presentation titled Clinical Pearls and Pitfalls, Lessons from Challenging Pediatric Ophthalmology Cases. The presentation will walk us through diagnostic challenges that might face the pediatric ophthalmologist and masquerade as routine cases, and we'll discuss surgical strategies for managing complex anterior segment cases in children, emphasizing how vigilance and precision can make the difference between saving and losing sight. Please join me in welcoming Dr. Ismail AlGhamdi.
أنا بغيت أصفق أحس بأنه واحد ثاني غيري. الله يعطيكم العافية. السلام عليكم ورحمة الله وبركاته. الله يحفظكم. It's my pleasure today to be with you presenting some cases that I encountered during my clinic and when I'm doing surgeries. Mona, when she told me I will present the grand round 10 months ago, I said, Wallahi, mashallah, we have time. But subhanallah, al-ayyam and the time are running fast. So she told me on January, you will have it on 14 October, and today is 14 October. We'll go together through a few cases. I try to divide the presentation into 3 parts. The first part, when you are in the clinic, you will face sometimes some cases that you feel it's easy and you think life is with time run easy. And with time you feel the diagnosis is the same, repeated, same diagnosis, same cases. But sometimes you will face something will shock you in the clinic. Mashallah, technology now and the presentation, you like it. You will see things even in PowerPoint. It will suggest for you additions and it will read your presentation and it will suggest for you things to put it in your presentation. This is one of example of the suggestion of the PowerPoint added to my presentation. I like it. So cases where attentive history and careful examination saved vision and life. We'll go through the first, let's go through the learning objectives. Recognize atypical presentation in pediatric eye, identify red flags during ophthalmic assessment, understand stepwise management of complex anterior segment cases, apply safe surgical principles in pediatric anterior segment cases. This is what inshallah, I hope we will get after the grand round. This is something we need to say it repeatedly in every lecture or in presentation. I don't have any financial interest, and all cases are my own cases from my clinic and from my surgery list, and it's purely for educational purposes. This is the first case. I was in my clinic, and a 10-year-old girl, she is a bright girl, intelligent with lovely parents. She came to my clinic with glasses. Actually, the appointment was asked by someone for second opinion. So when she came to me, she was diagnosed with amblyopia. And when I examine her, usually in my routine, when I examine, I put a routine for myself. For new patients, less than 6 years, I ask them to dilate for all kids screening with tropicamide. And for older than 6 years, I ask to see the otoref. If the nurse saw the otoref myopia, also dilate with tropicamide. So when I saw the child, she came to me cyclobleached because the autoref was showing minimal myopia. So she came cyclobleached, and the cycloplegia didn't match her complaint because she was 2100. And the cycloplegia was only minus 0.5, and she is wearing glasses, but her vision is the same. It's not changing, her vision. Nothing in ocular examination and in motility. I like something when I was digging. Can you scan it with your mobile and see, can you go through the form? And I will see your answers in 1 minute. If you face a similar case, what will you do? And the answers are available in the barcode. And let's see what you will do. Would you do the same as what I did, or you will behave differently? I put it start amblyopia therapy, prescribe new glasses, order neuroimaging, or re-evaluate in 3 months. Keep the child wearing glasses and re-evaluate in 3 months. We will see the answers. I will see it with you later. But what I did, I asked her one question. She's smart. She's an intelligent girl. I told her, was your vision the same 3 months before in the class? She said no. Even when I'm wearing the glasses, current glasses, my vision is not the same. I'm not able to see as what I was able to see before. So this rang a bell in my head, and I used, usually, well, like all of us, we are not doing confrontational visual field, color vision, except if you find something peculiar. So I asked her to confrontation visual field quickly in my clinic, and it showed abnormal visual field. Color vision was also abnormal. So I brought her again after 1 to 2 days to my clinic to be sure that the cycloplegia is not the cause. Again, I did visual field, automated visual field, and also it showed constricted visual field. Urgent MRI was done, and it showed supracellular tumor compressing the optic chiasm. And she was only 10 years, and she was labeled as amblyopia and seen twice in one of the tertiary hospitals, private sector. So I was, after 2-3 weeks from my diagnosis on her, I was in King Faisal in the clinic, moving around in the clinic. So I saw a young girl coming toward me with a band over her head, and she was smiling toward me with her parents. I saw this child when she approximated to me, and she is the same girl. She underwent surgery, and I saw her in the clinic as a walk-in, and she showed improvement in vision, and her situation improved. So this is very important. Ask simple question. Sometimes the smartest test is the simplest question. So the question that I asked her was the tool or the investigation that I was need to run the case. So when findings do not match the symptoms, stop, rethink, re-examine, and re-examine anterior segment and posterior segment. Don't rely on previous diagnosis. In a busy clinic, you will see it, and we do it. We tend to do it, especially if you see someone who's superior to you or senior to you, and you saw the examination, you saw the findings, you will run and put it the same, trying to see as much as possible cases. So even history from a child can be diagnostic. So ask kids, ask them, what do you feel? Don't rely on the parents only. Color vision, pupil examination, visual fields are your simplest but yet the most useful tools in the clinic. Let's have another example when simple esotropia isn't simple. I like one word was said by Dr. Christopher Lyon. He said, sometimes the most difficult things will hide in the, as what he said, and I didn't remember it exactly, but he said sometimes most dangerous things will hide behind things that you feel it's safe. And this is what happened in this case. He was 2 years old, and when I examined him, this is the first time to come to the in a clinic, he showed comitant esotropia of approximately 30 prism and full extraocular motility with +6 diopter hyperopia. So exactly this is the typical presentation of someone who will present to you with you feel it's related to hyperopia, esotropia related to hyperopia. So you will feel this is something related to accommodation. Again, if you see similar case, what would you do? I'm looking for your previous answers now. Let's see. And you can answer this one while I'm seeing the previous answers. Okay. I examined his fundus, and I was shocked when I saw exudative retinal detachment with pupil edema. The edema was extensive to a degree. It causes also exudative detachment. And the hyperopia that I found wasn't related to his refractive status. It was related to the exudative retinal detachment. So immediately I wrote for them a letter and I sent them to emergency and found to have increased intracranial pressure, proved by the MRI and by lumbar puncture. Luckily, I was in the same institute. The child was in the same institute, so I followed him up, and he was stable later on, and I operated on him, and he's following with me. He's doing fine now. He didn't underwent surgery, but he was fine on medications, and I'm following him up. So again, if you find something, run as usual. You feel that this is hyperopia, esotropia, don't miss examining fundus. You might see something. You were not able to find it if you didn't take seconds to examine fundus. This is another case, and this one was shocking for me. A child, 10 months old, he was wearing +8 glasses, and when he came to me, the parents, happy, they said, yes, at 2 months of age, when we noticed that the eye is deviated, we went to a hospital and examined, given glasses, and he's okay with glasses. Seen several times, not several, 2 times before he came to me. And the family happy, they came only for second opinion. When I saw the child, he is ortho with glasses, but I wasn't happy with the red reflex. So I examined the fundus. Right eye, I was shocked. Retinoblastoma, exactly, it's a retinoblastoma in the right eye. So when I shift 20 to the left eye, retinoblastoma again in the other eye. I was shocked. I wasn't able to stand at that time, because to miss retinoblastoma in visits with another colleague and only to give glasses without taking time to examine fundus. I know kids are sometimes tricky, difficult, crying, but take your time. If you feel anything abnormal, don't leave the child and without investigate him more. So again, I sent the child for another tertiary hospital for evaluation, and the family visited me, or I contacted them a few months ago. He's still under treatment. So bilateral retinal mass, it indicates that the child you need time to examine. So those 2 cases showing hidden pathology. Esotropia with hyperopia, but fundus examination showed pupil edema. And the second case, esotropia with hyperopia, labeled as accommodative esotropia, but showed bilateral retinoblastoma. I can understand, even you can understand that if a patient came to you with esotropia and no hyperopia, it's something, ring a bell in your mind. You will send for investigation. You might send him for MRI. But someone esotropia with hyperopia, this makes your life, you'll be relaxed, but don't. You should complete your examination. You should examine fundus. If it is competent, you might be more relaxed. If it's incompetent, you will be worried. But again, I did present a grand round a few years ago about acute competent esotropia, non-accommodative acute competent esotropia. So again, you need to dig more and ask and examine more. So the key message from these cases, in every squint case, always look at the fundus. It may show you more than what you expect.
What was the cause of this ICP?
Increased intracranial pressure, actually I don't know. he is under the neuro team. We'll go now through cases, surgical cases. I will try to show you a few cases that I had encountered, and from these cases, inshallah, we'll have lessons and we'll have peers. The first case is congenital pupillary occlusion. The second was iris lens membrane with cataract. And the third case is 3 cases. I will show you 3 video cases of 3 different patients with iris dialysis, phakic and pseudophakic, and how would you manage such situation. The first case was infant, and I was contacted by the residents on call in King Khalid Hospital. And when I saw the child, he was having right eye subretinal hemorrhage, and the left eye, there is pinpoint pupil with hemorrhage around the pupil. When we dig in history, we found that the child had obstructed labor. So it was difficult labor, and during the delivery, these things happened. So we tried to manage medically. We tried to use atropine, Bred 40, but right eye, the retina hemorrhage subsided. But on the left eye, the pupil continued to pinpoint, and scar start to form around the pupil. So I elect to take the patient to surgery at 4 weeks of age. Before, I dealt with him like cataract, like unilateral cataract. So at 4 weeks of age, we took him to theater and we did surgery. And this is the video of the surgery. And you can see here clearly that this is the area of the scar, and it's attached to the anterior capsule, firmly attached to the anterior capsule. The eye is rolling up. So what do you do in such cases if you have eye rolling up and the anesthesia was not able to control it for you? I like sometimes to use bridal suture, similar as ECC. So I took a suture, I pass it below the belly of the superior rectus, and this will stabilize the eye for me. I like to use limbal incision, or I like to go again to use peritomy to go at the limbus, because for 2 things. First, I might do BI, because sometimes you need to do peripheral iridotomy, so you can elevate the iris for you. This will make a separation between the iris and the lens. This will help you in doing the procedure. The second, because of ballooning of the conjunctiva. If you didn't do it, you will have a donut shape swelling of the conjunctiva. So I put the incision at the periphery. Then I used viscoelastic. I didn't do BI first. I said there is small eyelet here. Maybe if I inject viscoelastic material below the iris, maybe it will work. And it did work. I used this area with no synechia, and I elevated the iris from the level of the lens. And I made a balloon-like between the iris and the lens. Then, when I saw that the opening is good and adequate, sometimes I use 30 gauge to make the opening larger. But in this case, it was adequate for the acutome to go inside. So I used the acutome. First, it was dry. I enter it dry first. You can see this is all viscoelastic material. Then I entered with acutome. This is the acutome. And I enlarge the opening for me without the irrigation. Then again, viscoelastic. Then I connect it with the irrigation. And I draw a pupil inferiorly without risking the clarity of the lens. So I didn't bull this area. I didn't bull the scar, so I try to maintain the clarity of the lens. And it did work. Alhamdulillah, this child now, he's in 3rd grade in school, and his best corrected vision is 20/25. And he is only astigmatism of around -3 astigmatism. The family was also helpful because they were batching and they were following. I had seen him recently, and best corrected vision was 20/25. So this is the picture in the beginning, and you saw the end. So fineness over force. Excellent visual rehabilitation achieved with timely and delicate intervention. The long-term follow-up at 7 years. Now he is around 9 years. It's 20/25 visual acuity. This is nice, but you will not face it nice like this all the time. The second case was more difficult. This case will show you how difficult sometimes it will not be easy as the previous case. This child had a scar between the lens and the iris, posterior synechia, and it was 360. So I used the same tricks as what I said in the first case. I did the limbal incision. Let's move it. I start with the limbal incision, aiming for the same. If I'm not able to go through the pupil margin, I will do PI. I did both. I start at the pupil margin, but I failed. Then I did BI. But also through peripheral iridotomy, I was not able to separate. I was not able to elevate the iris from the anterior capsule. So what I did, I tried to forcefully open the synechia between the pupil and the anterior capsule through Sinskey hooks, through Coughlin hooks, through collar button. So I tried all my tools in theater to open and try to release. But whenever I try, there will be bleeding and pigments will stay over the anterior capsule. So then I did give up. I tried to open as much as I could. Then the only solution is to go and go with the vitrectomy. I took the cystotome and I opened in the anterior capsule. Then I used the occutome and opened the anterior capsule, removing the lens material, then draw a pupil in adequate size. And you can see. I like, by the way, some machines will give you the ability to change between cutting and, yes, and as a vacuum. So if you can have the sequence, I like to use sometimes cutting first, then vacuum second, or vacuum first, then cutting second. This will help you minimizing entry and going out. So you can use the occutome for all steps, from lens removal, pupil drawing, and anterior vitrectomy. So this is the end of the procedure. I left, actually, this child was infant, so we were not able to put an IOL. So this is the end of the procedure. Make sure not to leave any lens material inside, because those cases are prone to have glaucoma. And if you leave any lens material inside, the risk of glaucoma will be more. And this is what happened to this case. He developed glaucoma later. So in those cases, don't rush, take your time, plan the surgery nicely, and don't leave any lens material, because as I said, they are prone to have glaucoma. If you leave lens material, the risk of glaucoma will be more and escalated more. These are the two cases that are not trauma related, except the first one, maybe labor or delivery was the cause. But you will face sometimes cases with trauma, like this case. He had blunt trauma, resulted in iris dialysis. But luckily his lens was clear. There was no cataract. But the iris dialysis was large. It was 180-degree iris dialysis. This is the picture of the patient before surgery. And you can see through retroillumination how bad is the iris dialysis. This child had self-sealed corneal wound, and he came to us for further management. So what to do? We need to do a surgery to put the iris back to its configuration without risking the lens. So these are the steps that we did in this case. We did for him, first we did peritomy, conjunctival peritomy. Why? Because we need to suture the iris back to the sclera. So we need to have area we pass through the sutures. And this is your best friend, viscoelastic material. This is the best ally for you during surgeries. Utilize it. I utilize it to spread the iris back to its configuration. Then I used paracentesis to help me passing the Coughlin hooks. So the Coughlin hook, I like the curved one with the tip of it. I like to use it to stabilize the straight needle. See, I used it to stabilize the needle for me, so it will not touch the lens. And I used the surface of the iris also to prevent any touch to the lens. Again, use the viscoelastic all the time. And this is the Coughlin hook. So you see what I use? I use the curve of the Coughlin hook to hold for me the straight needle. And I pass it through the sclera, maintaining the clarity of the lens and try not to touch it. And we succeeded, alhamdulillah. At the end, the surgery went fine. And this is the, we used 2 Prolin suture, double arm. So 4 sutures, and this is the end of the procedure. We suture it, then we buried the sutures. We close the conge over, and the patient went fine. The surgery went fine, but unfortunately, usually what will happen to those cases of blunt trauma, what is the worst thing that they will have? Vision, yes, commotion retina. This is what always we have. This child had poor vision because of commotion retina. Another case, same scenario, but the lens was cataractus. So what to do? You have 2 options. The first option is to remove the lens first and suture the iris. The second option is to suture iris first, then remove the lens. Which one you will do first? It depends on how much iris dialysis. If the iris dialysis is too much, so suture the iris. If the iris dialysis is little, you can leave it at the end. So remove the lens, then suture the iris. And I will show you 2 cases. The first case was with 180 iris dialysis, again, but cataractus lens. Initially, we did anterior vitrectomy because there was vitreous in the anterior chamber. Then again, same steps. We used the same steps, and we sutured the iris back to its configuration with the Prolene sutures. But here you are more relaxed because the lens is cataractus, so you don't worry about the lens. You can do the maneuver or the surgery as you like, even if you touch the lens. At the end, you will have a nice round pupil, and you will be able to do your cataract surgery easily. The second case, I did it recently. I saw the cataract, but I saw the iris dialysis not much as the previous case. So you can see here, the iris dialysis is only small area here. So now I said, I will leave the iris at the end. I will remove the cataract first. I'll utilize iris hooks to dilate for me the pupil, and I put paracentesis, multiple paracentesis for the iris hooks. Then I had a good visualization for the, I used diathermy for capsulotomy. Then I removed the lens and I put a 3-piece IOL. This is my favorite IOL, sensor IOL. I put it in the bag. Then after I placed the IOL, I went to the vitreous and I did vitrectomy. You'll see I like to elevate the lens, then do vitrectomy. After I removed all my hooks, then I sutured the iris back. Again, after I do limbal incision, I sutured the iris back to its configuration using long Prolene sutures. So again, this is to show you things will be easy. You like to see it and you will enjoy seeing it. But when you face a similar case, think, put your strategy. It's like a match. It's like a football match. So you need to put your strategy. You need to think what to do and be sure that all things are available. This case also is a tricky case. I like it. I like to present it. This child had trauma and had repair elsewhere. Referred to us with traumatic cataract for further evaluation. When we saw the child, the colleagues in ultrasound mentioned intraocular foreign body. So I was happy. I said, this is a retina case. I referred to colleagues. But when they sent it back to me, they said the foreign body isn't in the vitreous cavity. It's embedded in the lens. So it's within, it's within your field. So I took the child, I went inside. When I removed the lens, I didn't see the foreign body. It wasn't visible. So I was shocked. Where is the foreign body? I asked for the B-scan again. They brought the B-scan and there is a foreign body, but it's in the angle. So what to do in such cases? Luckily, we were having the ECB with endoscope. So I utilize it. And you will see in the video how nice if you have similar tools, similar machines. Inshallah, Dr. Faisal Mubarak is not around because if you know that we are using his ECB, he might be mad. I didn't see his face. Dr. Ibrahim is around. I used ECB in this case. I enlarged the wound because I know that ECB need a larger wound. So then I put good viscoelastic material. At this time, I don't know where is the foreign body. It's in the angle, embedded in the zonules. But where? Is it on the nasal side, superior, inferior? Because, in the P-scan, we don't know. So I asked one of my colleagues in retina, he was in theater. I said, maybe the foreign body will fall down, so be ready. So we used it, and we went inside, and we were looking at the screen. Is it in this area, or is it in the other areas? This is the ECP endoscope. We were not able to see it here. It was at that area, the foreign body. After we visualized it through the endoscope, we said we need to do strategy. How would we remove this foreign body from the zonules? Luckily, I was having Dr. Abdullah Al-Musa, he is a retina, and he said, let's use our indentation. We'll use indentation, and you can see the foreign body embedded here. Inside, with indentation, you will be able to visualize it. See? So I used large forceps, and I hold it, and I took it out. After I put a good amount of viscoelastic material, preventing, inshallah, it from falling down into the vitreous cavity. It was the pencil, the head of the pencil. It was broken inside the eye. Then I put IOL after, this is the 3-piece IOL. Again, we put it inside the bag. Those are cases with trauma. How about cases with Becky B? Sometimes, because I had 2 subspecialties, sometimes I see cases, they are in need for Becky B. But this is one of the sad cases that I encountered. This child, I was doing round in the floor, and they told me we have a child Down syndrome, query, he was around 9 months, 10 months, and colleagues asking, is it perforation or is it smatocele? Is it in need for further evaluation or only observation? So I went to see. The child was Down syndrome, and he was having perforated cornea. The perforation is difficult to judge in pediatric kids because they will not be cooperative with you. So the first thing you need to do is to complete your examination under anesthesia. So I took him in theater, and I asked the theater, do we have graft? They said, we don't have good graft for kids. We have it only for tectonic. I said, okay, what can we do? This child is in need for emergency tectonic graft. So the goal here is not fission. The goal is to salvage the globe and to save the globe. So I took him. You can see clearly that this area is perforated, large perforation, and it was exposure related. A case of Down syndrome with hypotony and problems, and he wasn't having ability to close the lid completely, with multiple admissions to the hospital, and he ended with perforated cornea. What I did during surgery, I tried to put the iris in its configuration, so I tried to release it through paracentesis, but there was a lot of non-viable tissue, so I cut it. Again, I tried to push it back, the iris, whatever I could. Then I did conjunctivotomy to increase the size of the area. Then I measured the size of the graft that I will put, and it was around 5 millimeter. I did conjunctivotomy late after. And all to prepare the area for the graft. In those cases, I wasn't able even to put Fleringa ring because it's open globe. So you need to minimize pressure as much as you could. And again, as I said, the best friend for you here is the viscoelastic material. Again, those cases you need to ask your colleague in anesthesia to give mannitol, to give Diamox, to decrease the pressure as much as you could. After doing the peritomy, I did marking. Then I used the handheld Trifine. You will see it now. The Trifine handheld after initial cut, I used the super sharp, then scissors to the right, then to the left. After I cut the recipient cornea, before completing cutting, I like to use one strategy. I cut the donor cornea and I place it over the recipient cornea and start with one suture. I start with whenever area is possible for me. So I started here. I put one suture here, making things ready. If anything happens, I can quickly suture the eye before anything happens. So you can see it. This is it's not clear because it's tectonic. It's not good for pediatric, but we used it to salvage the globe. So then complete cutting and quickly suturing the graft in place. And this is the end of the sutures. You will see at the end after. I like interrupted sutures because if one suture cut, you can replace it. But in continuous, if it cuts all. Then I did BI and I increased the size of the pupil because I know this area will not be useful for the child. And you can see the pupil here. So I went inside and I did create, with the vitrectomy machine, I increased the size of the pupil so it will be adequate for the child vision. Suture, close. The child is following till now with me. Alhamdulillah, his lens was maintained clear. This is another case, again, another BKB, but this case had grafted before, and he had Ahmed valve. The valve was touching the lens, and he developed cataract. So he is having opaque cornea, and on top of it, the lens is opacified. So you need to remove the graft, and you need to remove the lens, and you need to trim the tube. So it's a 3-in-1, more than head and shoulders. So what I need to do, I need to go and have a good graft. So I asked the people in iBank, please, I need a good graft for a child. So they provided me with a good graft. Then I opened the previous interface between the donor and recipient. I tried to open it with Sensky hooks, slowly, carefully, then open it with a super sharp and try to cut it later with the forceps. Now the most important things, anyone can tell me what is the name of this hook that I used? Maybe not clear, but it's the same as the one we use it in open globe injuries. What is the name of it? Javis. So I try to use it to remove any pressure from the eye. Sometimes I like to suture the Flaringa ring, suture it to the globe, and suture it also to the hook. So it will pull the eye superiorly to trying to maintain the scleral rigidity. Then again, I use the same, it's open sky technique. So when I opened, I saw the tube touching on the lens with cataract. So it was, we call it open sky technique. I tried to stain the anterior capsule, then removing the lens through vitrectomy machine. And again, as I told, I like the machine with the sequence. You can play with the sequence. So no need to change the machine. So you can continue with the vitrectomy. I did a lens removal. Then I put the IOL. I did anterior vitrectomy also, posterior capsulectomy, anterior vitrectomy. Then I put 3-piece IOL in open sky technique. We put it inside the bag. Then we sutured the graft in place. The child, alhamdulillah, he's fine. He's doing fine. But you know, those cases, Dr. Mohammed Abu Saif was consulting me a few weeks ago. He had a child with bilateral congenital glaucoma and opaque cornea, but one eye is good. The child is able to mobilize. We are able to refract him. And he was pushing, he was thinking to do grafting for the other eye. I said to him, please, no, don't. He is fine. He is doing fine. Don't do it. Same time, after a few hours, I saw one of my cases. I operated on him. I did grafted him a few years ago, and crystal clear graft. He is fine. I am able to refract him. I'm able to see him, and he is in school. But he is studying Braille. He is not able to see. Even though the graft is clear, so I took him to Dr. Abu Saif. I said, please, see this child, even though with a clear graft, but it didn't work for him. He's in a deep amblyopia. So save him from this difficult procedure if he's having the other eye, which it's good. This is our end. We, the precision reflex compassion always aim to preserve or restore normal anatomy. maintain anterior chamber stability throughout any procedure. Viscoelastic is your most reliable ally, so use it generously. Don't look at the nurses, they will tell how many are you open. Don't look at them. Do it whatever you feel it's good for the patient, for you, do it. Protect corneal endothelium and lens, maintain the lens capsule or lens if it's clear as much as you could. And every movement, this is what I'm telling my colleagues, residents, every movement you do inside the eye, you should have a purpose for your movement. Be careful not to do anything will harm your patient. This is a hand writing of one of the children that I treated. She was 2 months when I operated on her. She had bilateral cataract. And when I operated on her, she was 2 months. Now when she wrote this letter to me, it was a long letter, but I show you only my name. She is now in 3rd grade in school, and she is around 20/30, 20/25 vision with correction. She was happy. She came with her 2 brothers. Both are normal. The letter was nice. What I like about her letter, not the words, it was nice, but what I saw behind the words. She was saying to me, I'm in school, I'm studying, I'm similar to any other child. I was happy with that letter. Sometimes the most powerful message come in the simplest handwriting as what we see here. And children remind us always to give back light to those who were born with it, to see it like kids. وكنت كتبت I like to write, so what I wrote لا يوجد في الحياة من أصدق ولا أنقى من الأطفال فإذا أحبك طفل أو تذكرك واشتاق إليك فذاك شرف كبير وفخر لا يقدر بثمن لأن مشاعر الأطفال لا ترتبط بالمصالح والماديات ولا تشوبها حظوظ النفس والشهوات إنها مشاعر الفطرة النقية الخالصة الشفاف. I like to keep messages from kids like this. Thank you. This is end of our lecture. Inshallah it was. Okay. I think we have time if any comment or questions, or you like to continue with the case presentation. I like today to present the cases similar way. So I ask my colleagues from residency to present 3 cases, which will be the continuity of what we are talking in the grand round. 3 cases also clinically useful, and we will have lessons from it. It's up to you. You like to have few questions, open it for the colleagues, or you like us to continue with the case presentations? I think I took the mic from moderator.
No, it's okay, Dr. Ismail. First of all, thank you. It was an excellent presentation. The cases are really rich and fruitful. We can learn a lot from them. I think the residents are lucky to be exposed to these cases from an early stage. I was wondering if anyone has any questions for Dr. Ismail.
تفضل يا كابتن.
Thank you, Dr. Ismail. Very nice cases. We learned. Good to see the cases also with the photos and the videos that you present is very nice. My question regarding the first case where you did the MRI and then you found a tumor pressing in the chiasm. Was there any abnormality in the optic nerve? Like when you know that the MRI is abnormal, sometimes you go back again and see the nerve. Did you see any?
Nothing. This is what was surprising me, nothing. I wasn't able to elicit anything on the optic nerve. And she had been seen with 2 before me. And both labeled her normal. They labeled her amblyopia. They said to the family, you have amblyopia. The question that, why the question? Because when they said amblyopia, I asked her if amblyopia, nothing will change. She should have the same vision, but she said no. 3 months ago, I was able to see board. I was able to see nicely.
Thank you. I just want to emphasize also in the point that you mentioned regarding the patient who presented with esotropia and then they found out to be retinoblastoma. So this is important message whenever we see squint in pediatric, examine the fundus, even in the ER. Sometimes we see the patient in the ER and you ask the patient, how long do you have this squint? They will say, since the age of 2 months. then we say this is not emergency, you go out from the ER. No, since a pediatric presenting to the ER with squint must to have the dilated fundus exam. Thank you for bringing those nice cases.
السكوت علامة الرضا ما في حد.
Excellent
Inshallah.
point, Dr. Abdallah. I just wanted to add, when you said you asked her an extra question and she told you that something is different. So for any vague visual complaint, usually you should perform a visual field, and it's difficult for them to sometimes describe what the visual deficit they're having is. So if the visual complaint doesn't make sense, or the patient has 20/20 vision or has a small refractive error, always think of something affecting the patient's visual field.
And confrontation of visual field, we used to teach it to the medical students. But at that time, I felt it's very nice examination, because usually when you do it, people will answer you normal answers and correct answers. But that child was shocking for me when she said, no, I'm not able to see. Whenever I do it, she is not answering normal answers. So I felt the importance of the confrontation of visual field.